So the thyroid gland is a butterfly-shaped gland. It's right here, right behind your trachea. You should not be able to palpate it. If anyone here can palpate their thyroid gland, that means it is enlarged. So if you can't palpate it, good. So what's the purpose of the thyroid gland? It produces three hormones. They are T4, T3, and calcitonin. T4, T3 are the active hormones which affect your metabolism. Which metabolism does it affect? All the body's metabolism. So every cell in the body is affected by the T4 and T3 levels. Sorry? Echo? Hello? Better? Calcitonin will lower the calcium levels in the blood. Okay, so this is the opposite of the parathyroid hormone, which increases calcium levels in the blood. I repeat, calcitonin, which is the third hormone produced by the thyroid gland, works to lower serum calcium levels. So here's the location. How it works is it's another endocrine gland, so therefore it's subject to the control of the pituitary gland. Just like any other endocrine gland, they are controlled or at least influenced by the thyroid gland, the pituitary gland. So their release is controlled by TSH, which is thyroid stimulating hormone. Now, this hormone is released in response to the levels of T3 and T4 in the blood. So let me sum it up. The thyroid gland produces the T3 and T4 hormones. Their release is controlled by the pituitary gland, which releases TSH in response to T3 and T4 levels in the blood. The relationship is inverse, meaning if at any time your T3 and T4 levels are low, then that means the TSH secretion will increase in order to stimulate the release of T3, T4. Vice versa, if your T3 and T4 levels are high, then TSH levels will drop. Does that make sense? Okay, because we respond by our body works by negative feedback, correct? So that's another example of negative feedback mechanisms. Any question about that? Very good. I already said that the function of the T3, T4 they're going to influence the metabolic rate of the body. Which cells? All cells' metabolism will be affected. Okay, and I already mentioned the function of calcitonin. All right, so we're going to talk about two problems here. There are only two problems in with the thyroid glands. It's either hypersecretion, although there are different types of hypersecretion, meaning hyperthyroidism, can be autoimmune or it can be also secondary, or what also we call iatrogenic hyperthyroidism, or we don't have enough, which is hypothyroidism. It can also be, again, autoimmune, or it can also be iatrogenic, meaning treatment for one problem will lead, unfortunately, to the other, vice versa. Okay? Regardless if it's primary or secondary, or if it's iatrogenic. Okay? Okay, I'll go straight to the disorder. First one is this page just tells us about the diagnostic testing, which are, of course, TSH, T3, and T4 levels. Okay, there's not much to read here, except for this test. This test involves the use of a radioactive iodine. Now, there are two forms of radioactive iodine. RAI 123 is a diagnostic test. So RAI 123 is a lower dose of radioactive iodine used only for diagnostic purposes, meaning we use iodine for testing because iodine is only used by the thyroid gland. No other parts of our body uses iodine. So it makes it a very specific test. So to do this test without harming the rest of the body, that's why we perform it. Okay, so it's exclusively going to give us information about the thyroid gland. Okay, so a very specific test. Now, later when we talk about treatment, there's another radioactive iodine we use, this time a higher dose radioactive iodine used to treat hyperthyroidism. Okay, so I repeat, RAI 123 is not for treatment. This is a radioactive dye. However, it will only be used for diagnostic purposes because it's a lower dose, therefore it's also a short-acting radioactive iodine, meaning it has a very short half-life. In a few minutes, it's gone, right? Whereas RAI 131 can last over a couple weeks, okay? All right, let's get straight to the disorder. So here's our first problem, hypothyroidism. As I mentioned at the beginning, there are two forms here. The most common form is the autoimmune form or primary hypothyroidism. This is called Hashimoto's disease. So it comprises majority. Now, the population affected by Hashimoto are mostly women. There are male patients, but they're very rare, okay? Most common are females. So patients you see in nursing homes or in the hospital taking thyroid hormones are mostly female patients. Since this is autoimmune, do we know the cause? No idea what causes it. And the age group, again, females mostly. Another possible cause is radiation to the neck, meaning you had some form of cancer, for instance, and you were treated with radiation, and that tumor is in your head or in your neck, meaning you get exposed to the radiation, correct? And that affects your thyroid gland. That can also lead to hypothyroidism or to Hashimoto's disease. Manifestations, everything will be slow because again, the function of the thyroid gland is to produce T3, T4. Therefore, if that gland is hypoactive, you will have low levels of T3 and T4, resulting in decreased cellular metabolism systemically. So we're talking about your heart, your brain, your lungs, your GI tract, everything. It will be slow. Manifestations, of course, are the following. So we have here a figure, 45-5. You have the manifestations here. However, for exams, I will go with the paragraphs because the explanation is mentioned in the paragraph. So each paragraph explains why there is fatigue, why there is irritability, or why the patient mental process is apathetic, for instance. Okay, so the explanation will be in the paragraphs. So here are your manifestations. Now there is a increase in the size of the tongue that it doesn't fit in the mouth anymore. So therefore there will be tongue protrusion. Okay, they'll at rest they will do like this. Of course, when they talk, it fits in the mouth. Okay, but whenever they're resting, it seems to come out of the mouth. And they have this apathetic look, okay, like this, a blank stare, and they're slow to respond. So if one of you here in class have Hashimoto and not treated, this will be challenging because your IQ actually decreases, okay, if you don't treat hypothyroidism. And we'll look at the life-threatening complication later of untreated or undertreated hypothyroidism. So as I mentioned, it affects all body systems. So figure 45-5 tells you system by system. So from the brain activity to the heart, lungs, when we mean lungs, we also include the breathing muscle, the diaphragm is also included. So GI tract, there'll be constipation. Now, take note, even though if this patient has decreased appetite, meaning they have no appetite, they don't like to eat, they will continue to gain weight though, because their metabolic rate and therefore their metabolic needs decreases. So whatever little food they eat turns into fat, okay? Because they burn very little carbs for energy. So all of that becomes fat. There will be edema, of course, because circulation is slow as a result of low heart rate and low blood pressure. So that will lead to peripheral edema. So I mentioned the severe form earlier, which is a complication again of either untreated or undertreated hypothyroidism. Now, the scenario could be that the patient doesn't have insurance, never got diagnosed, so they're living with hypothyroidism without treatment, so that can lead to myxedema. However, it can also be where the patient is diagnosed and they're taking a certain dose of the thyroid hormone replacement. However, they either went into surgery or got sick, some stressor. The patient was exposed to some stressor, whether emotional or psychological or physical stressor. Now, what happens to our metabolic needs when we are sick mentally or psychologically or physically? It increases our metabolic needs, actually. We require more energy, more calories when we are sick. However, since these patients are taking the same dose when they were not sick, so during periods of mental or physical illness, is the dose they're taking adequate for the increased metabolic need? No. So can that lead to the complication as well? Yes, that can lead to myxedema. So here it is. Myxedema is a rare life-threatening condition. Now, this is no additional manifestations than hypothyroidism. This just means all the manifestations we saw earlier become severe. Meaning, will this patient be awake? No, they'll be either lethargic or they'll lose consciousness. Their heart rate will be really low. Blood pressure will be very low. Okay, they can actually go into shock. As far as breathing, they can also go into respiratory depression, right? So that's how severe myxedema coma is. Think of it as a really severe form of hypothyroidism. Okay. What are the two most common causes again? Patient was not diagnosed, therefore not treated, or the patient was exposed to some stressor, okay, that they ended up taking inadequate doses of the hormone replacement. So this condition, if you read the rest of the paragraph, again, undiagnosed hypothyroidism or some stressor. Other stressors would include they were given CNS depressants. Examples are opioids or for surgery, anesthesia. Okay? So when they are exposed to benzodiazepines, that can also trigger a myxedema coma, because what happens to their kidneys' ability to eliminate the drugs that we give them, especially CNS depressants? It's also decreased, right? So meaning liver metabolism is also decreased because all metabolic rate in the body, every cellular metabolism is affected, right? So these are the complications that result. So mentally, they will have depression. Yeah, like I said earlier, the IQ literally will drop. And the rest of the symptoms are here. Management, this is pretty simple. Because this is autoimmune and diagnostic wise, by the way, let's see, okay, I don't have the table here, but let's examine the diagnostic testing. So I mentioned TSH and T3, T4 levels here. So in Hashimoto's disease, what's the problem in Hashimoto's? Why is the T3, T4 levels low? What is the nature of this problem? It is autoimmune, correct? Meaning our body is destroying the thyroid gland. So therefore, the thyroid gland, can it make adequate T3, T4 levels? No. So the problem is with the thyroid gland. You agree? Okay. So what will be the response of the pituitary gland when it senses that, oh, T3, T4 levels are low? What will it do to TSH levels? It will increase TSH levels. So therefore, the lab work here, what will it show in Hashimoto's disease? What will be the TSH level? High. T3, T4 levels will be low. Now, in response to that though, TSH will have an effect on the thyroid glands. So the TSH will cause the thyroid gland to work harder. However, since it was destroyed partially by autoantibodies, is it physically able to increase T3 and T4 production? It can't. However, will it try to? Yes. As a result, will there be an enlargement of the thyroid gland? Yes. So it's not true that you will only see goiter. Goiter is the enlargement of the thyroid gland. It's not true that you will only see that in hyperthyroidism. It can only also be seen in hypothyroidism, in Hashimoto's disease. Okay. So let's resume treatment. So since there's nothing we can do, there's really no successful treatment for autoimmune disorders. So since the thyroid gland is hypoactive, the only thing we can do to help the patient is to give them the hormone. Okay, we'll give them the actual T3, T4 hormones in the form of a pill. It's also available in injection, parenteral injection, and also in a liquid form. Okay. Obviously, if the patient is in mixed edema, right here, wherein the patient is lethargic or unconscious, stuporous, can they take anything by mouth? No. So that's why we have the available IV form, okay, to treat patients in mixed edema, which is life-threatening. Levothyroxine is the hormone, synthetic hormone, comes in different brands, but the generic name is the same. They're all called levothyroxine, but there are, again, different brands. Armour Thyroid, there's Synthroid. Now, the rule for dispensing levothyroxine is the doctor will specify a brand because brands apparently differ in the formulation, meaning 75 micrograms of Armour Thyroid is not the same as 75 micrograms of Synthroid. Does that make sense? Meaning between brands, although the same generic name, strangely does not have the same strength. Okay, so when the patient is already taking, let's say, Armour Thyroid, they should stay with Armour Thyroid. Okay, so this is one exception wherein we have the generic law, right? Generic medication law that was signed into law years ago by, I forgot who the president was. So it required physicians, all providers, nurse practitioners, DOs, MDs to write all prescriptions using the generic name only. This is one exception. All right. So in this particular case, the doctor has to specify the brand and the pharmacist cannot replace it. If the doctor wrote Armour Thyroid, the pharmacy has to dispense Armour Thyroid. Okay, this is just one exception. Now, because the patient was hypothyroid for a while before we diagnose them and then they receive treatment. So it's been a while wherein the heart function, specifically the heart function, has been used to very little T3, T4 levels. So because of that, the patient has developed some heart damage during that period. Okay, so we may or may not have diagnosed it yet, but for this reason, the dosing must be the lowest possible dose when starting, because it's not the same when it's our own thyroid gland producing that T3, T4 versus taking levothyroxine. We don't know how the patient's heart will react to synthetic levothyroxine. For this reason, we start we start low and go slow, meaning it's important for you to explain to the patient that, yes, this dose that the doctor ordered for you may not see any significant changes until several months later. Sometimes it may take years before they see any changes because the doctor is very cautious about increasing the dose. So let's say I started levothyroxine today, and after 1 month, for instance, I go back for my follow-up checkup and then I complain to the doctor, hey, nothing's happening. I'm still having the same. I mean, a little bit improvement, but not really back to how I was before I was diagnosed with this. The doctor will not agree with increasing the dose right away. Okay? The doctor will tell the patient, or me, for instance, the patient, that be patient. Okay, I cannot increase the dose this fast because I don't know how your heart will react. This may result in possibly a heart attack or severe increases in heart rate. Okay, so we're worried about cardiac function in when regards to thyroid hormones. Are we clear? Okay, so it has to be slow. Okay, and we increase any changes, whether we increase or decrease the dose, it has to be slow. Okay, this is one thing wherein we cannot expect a sudden improvement in symptoms. Okay, the patient will have to just deal with that. Okay, so we're really worried about angina, which is chest pain, or arrhythmias. Okay, with changes in the dosing, especially when it's new, when the patient is newly diagnosed. So here's the warning regarding that. Okay, so watch for cardiac and also respiratory function in these patients with hypothyroidism. Medication reinteractions, here are a few things that will affect it. Mentioned specifically are estrogen, which are your female hormones. These could be in the form of birth control. Although hypothyroidism affects women who are middle age and older, meaning it starts right around 30 or 40 years old when this affects the females. Unlike Graves' disease, which is the opposite, which starts around 20 years old. So this one is more like a middle-aged woman, okay, 40s and up, when they get diagnosed with Hashimoto disease. As already mentioned earlier, even in small doses, so CNS depressants like hypnotics, sedatives, so most of these are benzodiazepines, opioid drugs, anesthetics. Anything that will cause CNS depression must be used with caution in these patients. Again, drug levels will accumulate because of decreased drug metabolism, decreased drug excretion by the kidneys. So be careful. So watch them for toxic doses, which can lead to respiratory depression or respiratory arrest. Supported therapy will be nothing to do with the hormone, but treating the symptoms. Because is the patient feeling cold here or hot? Do they have cold intolerance or heat intolerance? They have cold intolerance. So what would be supportive therapy for that? Okay, dress them warm. Okay, dress them warm. Okay, can we give oxygen? Because the breathing is low. Yes. Okay, how do you speak to them? Are you going to hurry them up? Hey, finish eating. Hurry, 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 hurry. Get up to the bathroom. Hurry, hurry, faster, faster. Okay, so allow for extra time. because these patients are slow. Okay, so we have several nursing diagnoses here. I'll go straight now. I'll leave you responsible for the supportive therapy. I'll go straight to the complications now for management of myxedema, the life-threatening complication. Again, here is a warning. Now, another thing I want to remind you is these are hormones, correct? Meaning, how long will they be taking these hormones for if they have Hashimoto? Forever. So, if they don't take it today, what will happen to them? Remember, the T3, T4 levels are low. If they don't take their dose today, what will happen? What happened to respiratory, cardiac, GI, neuro function, kidney function? Everything will be decreased, right? Can that be dangerous? Yes. So what will happen if these patients are NPO? Let's say they're here because of another problem, they're placed on NPO, or let's say they're having a procedure, a surgery, for instance, they're NPO. What do you do? What is your responsibility? Can we stop these drugs? No, this is one exception. See, so under the SCIP, which is Surgical Care Improvement Project, a Joint Commission core measure. So Joint Commission says this is one of those drugs that should not be stopped. This is the same as steroids. So hormones like this, steroids, beta blockers, those drugs or anti-seizure medications, those drugs should never be stopped. All right. So if you have a concern, oh, well, the patient's NPO. Well, what do you do then if they're NPO? Okay, ask for an alternate formulation of the drug. Are we clear? Okay, so certain medications cannot be stopped. You know this, right? You learned this in pharmacology. What do we do if we need to stop a steroid? Taper slowly. We never stop it right away. Same thing goes for anti-seizure medications. So I'm taking anti-epileptic medications. What happens if I stop suddenly? I could have a breakthrough seizure. Okay, so same reason for these hormones. So here are your teaching. Make sure they understand it. Okay, lifelong therapy should be taken every day, and then tell them, okay, what if I can't take anything? I'm vomiting. So what do you advise them to do? Vomiting. I'm having diarrhea. I can't hold anything down. Or if the patient's unconscious, what should be done? Okay, call their doctor or go to the ER. Okay, this patient is hypothyroid. Okay, they can't take them. So please advise what to do. Okay. And what time do they take them? First thing in the morning, empty stomach. So what time will this be on your MAR? Either 6 a.m. or 6:30. Right? So always before breakfast. So this falls under whose shift? Night shift or day shift? This will be night shift. I hate this drug because if I work nights, what am I thinking about at 6:30? I'm gonna clock out at 7:30. I'm out of there, right? I don't want to have to, because what will these patients do? They are hypothyroid. So are they gonna be up and about early in the morning? No, these patients will sleep in, right? So it's hard to wake them up. Hey, I have your pill for you. Okay? So what do I do if they refuse? And no, I'm not waking up. No. And they'll go back to sleep. So what do I do? Pitch it and say refuse? No, I should not do that. It's better that I do what? Endorse it to the next shift. Okay, I'll try my best to wake them up to give it, but if I can't, should I cancel the drug because and write refused? No, it's better to give it to the next shift. Okay, hey, can you try? Okay, it's an important pill. Okay, they should not go without these hormones. Are we clear? Do we understand the implication? Okay. That it has effects on their cardiac and respiratory function, right? So it's important that they do not skip these hormones. Okay, this is the only source. These pills, these injections, that's it. You cannot go without them. We already discussed when to seek medical attention and nutrition, and then regular monitoring. Okay, so they need to monitor TSH, T3, and T4 levels, okay, while on this therapy. And that's it. Any questions? All right, let's go now to the other problem. Hyperthyroidism. Same as hypo, this has a primary and a secondary. Primary is always autoimmune. Secondary caused by something else. For instance, I forgot to mention. So here under hypothyroidism, if they end up taking too much of the hormone, what will happen? They will have hyperthyroidism. Is that clear? Now, if you ask, how does that happen? Well, I mentioned earlier, does our metabolic needs stay the same? So let's say I was diagnosed at 40 years old. I'm a woman. I'm taking levothyroxine when I'm 40. What happens to my metabolic needs when I turn 60, 70? Is it the same as it was in 40? Do I require more or less? When I'm 70, 60, so my metabolic needs is higher when I'm 70 or 60? What am I doing at 60, 70? Am I working? Am I toiling as I was in my 40s? No, I'm getting ready for retirement. Okay, so therefore, what happens to my metabolic needs as I get older? Decreases. If I take the same dose, what could happen? As I was in my 40s, can I develop hyperthyroidism? Okay, you understand now. However, there is as I said, there is autoimmune form. The autoimmune form of hyperthyroidism is called Graves' disease. Probably heard of that term. We have a few celebrities. I also had classmates in college who had Graves' disease. So this is now, Graves' disease is the autoimmune form. So this is the equivalent, the counterpart of Hashimoto. Hashimoto was the autoimmune hypo. This is the autoimmune hyper, okay, Graves' disease. And of course, the iatrogenic or secondary form of hyperthyroidism is a result of treatment for hypothyroidism. Okay, too much hormones, I became hyperthyroid. Right, so for this chapter, we'll focus on Graves' disease. Okay. So manifestations, total opposite the hypothyroid patient. So if you had a very slow, low IQ, fat, sleepy, lethargic patient, constipated patient, cold intolerant patient in hypothyroidism, what do you have in hyper? The most hyperactive, the most restless person, the most anxious patient you can have, right? So this is like a chicken, okay? Like this, they're always active, they're always hot, regardless of the weather. They're undressed, they're wearing tank tops in the middle of winter. Okay, they could be in the blizzard wearing a t-shirt, right? That's how heat intolerant these patients are. They'll be sweating all the time. Now, how does that feel? Your heart rate's always fast. Okay, you feel nervous all the time. Your blood pressure is so high, you're sweating. Okay, how do you feel when you're wet and sweaty in the middle of summer and you're out on a date? You feel really sticky, right? Very irritable. So that makes you more annoyed, more irritable, right? You moody, right? So and you could have a stroke or a heart attack here. That's how high the heart rate and the blood pressure will be with these patients. They have diarrhea, they'll eat nonstop, but they continue to lose weight because even in their sleep, the metabolic rate remains high. So can they eat while sleeping? Of course not, okay? But there's very little sleep here. Unlike in hypo, wherein they're sleepy all the time, these guys hardly get any wink. So they'll have insomnia, okay? Very hard time sleeping. Again, everything is high. So they have They also have high libido. Okay, they have increased libido. However, they'll have problems with conceiving because they have oligomenorrhea. Sorry. Okay, they do not menstruate, so can have or they can attempt of getting pregnant, but they can't get pregnant. Okay, because they're not ovulating. I already mentioned the cardiac effects. So the sympathetic stimulation is constant here. So they'll have high levels of catecholamines, the epinephrine, norepinephrine. So they feel nervous all the time, palpitations, high blood pressure, sweating. They're nervous, delirious, even disoriented. They're hungry all the time. They're hot, so they're always asking for ice, okay, a cold towel, and they don't like people. Okay, so your frequent visits, let's say you make rounds, they don't like that. Okay, so what would be a good room assignment for this patient? What will you put this patient? Close or far from the nurse's station? Okay, put them farther because they don't like noise. Okay, although they require constant supervision, meaning close monitoring. However, you don't want them to be annoyed either because just like if hypothyroidism has myxedema, a life-threatening complication, these patients will have what's called thyroid storm, which is the opposite, like a severe form of hyperthyroidism. So same symptoms you see here, but really severe, okay? Really high levels of hyperactivity, high blood pressure, really sky high heart rate. And just like in hypothyroidism in Hashimoto, they may have an enlarged um, thyroid gland as well. Now, the reason here, of course, is what happens to their T3, T4 levels? Very high because the gland is hyperactive, correct? So if a gland is hyperactive, just like let's say the penis, if the penis is hyperactive, what happens to the penis? You will have an erection, correct? So what causes an erection? Why would it go from like this to now this? Why it makes it so hard? Like when you take Viagra, how does Viagra make it hard? What happened to the penis? The circulation. So there's increased blood flow to the penis. So in the same way here, if this thyroid gland is very hyperactive, producing so much T3, T4 levels, what happens to the circulation here? Very increased. Okay, so the vessels are so large, this is so dilated. Okay, so the blood vessels here, both arteries and veins, are very dilated, and therefore the gland enlarges. All right, you follow so far? Okay. So all the functions again, opposite what you saw in hypothyroidism. I'll let you finish that. And let's go to the lab. So if T3, T4 levels are high, therefore what happens to the TSH here? It decreases. Okay. Now let's go to management. Unlike hypothyroidism, wherein it was simple, we simply replace the missing hormone or the decreased hormone levels. This one will have to decrease the T3, T4 levels. Okay, so we have several options here. Plus, there are cardiac involvement here. So we're going to have to treat the cardiac symptoms as well. First option is the age, by the way, is between 20 to 40. That's the onset, although these patients will go on to have hyperthyroidism until they grow old. So these are the options. And the doctor and the patient chooses based on their age and circumstances. For instance, if they're pregnant, then that changes the treatment choice. Okay, I'll show you how. The first option are one option are anti-thyroid agents. So there are two drugs mentioned in this chapter. They are called thionamides. They are methimazole and propylthiouracil, or PTU. We also have radioactive iodine. I mentioned this earlier under diagnostic testing. However, this is to treat the Graves' disease. So therefore, this is now RAI 131. Earlier, for diagnostic purposes, it was RAI 123. This is 131. And then finally, surgery. There are supportive treatment here as well. I mentioned the cardiac medication. So the So those are our options. So either give them antithyroid meds, which are teratogenic. What does teratogenic mean? They can cross the placenta. So therefore, what's a contraindication for these drugs? Pregnancy. And since these are, again, childbearing women, childbearing age 20 to 40. So what should be taken while they're taking these drugs? Contraceptives. Okay, so they need to stay non-pregnant, because otherwise if they get pregnant while on these, what will happen to the baby? You don't want to find out. Okay, so radioactive iodine, same thing. So this can be harmful to pregnancy. So surgery is a option if they don't respond to antithyroid or radioactive iodine therapy. So the supportive treatment is beta blockers. So this has nothing to do, this will not affect hormone levels. This will only treat the cardiac symptoms. This will help lower the heart rate. Therefore, they're not as shaky, because your heart rate's high, you have tremors, yeah? You're shaky, you're nervous, and this will also help lower the blood pressure. All these three treatments, whether surgery, antithyroid medications, or radioactive iodine, will cause what? Since they're going to destroy or remove the thyroid gland, what will the patient develop as a result of therapy? Hypothyroidism. Okay, that's the sad consequence of treating hyperthyroidism. Then once they have hypothyroidism, then they'll be taking levothyroxine. For how long? Forever. Hypo? Yeah, it'll be hypo forever. All right. So for drugs, so we'll do radioactive iodine and the thionamides. So let's start with radioactive iodine therapy. Now the patient swallows the radioactive iodine. Okay, so they take it by mouth. I already mentioned we test for pregnancy first before starting this therapy. And after the end of the treatment, they are advised to continue taking the contraceptives for how long? Another 6 months, okay? Because that tells you what happens. Is there still remnants of the radioactivity in the body? Yes, up to 6 months. Okay, not much, but it can still be harmful to the baby. And also for breastfeeding, so let's say the patient is breastfeeding, so no breastfeeding up to 6 weeks. Okay? All right, because we swallow this, can this enter other body systems? Yes. So this is what we call a form of brachytherapy. That means it's internal radiation. So radiation therapy like this one, it enters body fluid. So therefore, anything wet coming out of this patient for a certain period of time will be radioactive. Give me examples of body fluids that will be radioactive. Saliva, urine, feces, mucus. And remember, mucus is also present in the reproductive organs, right? So your vaginal secretions will also be radioactive here. So no sex during the therapy, okay? Because you will expose the partner to radioactivity. So over a period of weeks, thyroid cells are exposed to the radioactive iodine. But sadly, some remnants of the radioactivity enters body fluids because again, the patient swallowed the radioactive iodine. Okay, let's talk briefly on thyroid storm, and then I'll come back to this paragraph so you understand this particular paragraph. Let's go to 45-6 right here. What is thyroid storm? As I mentioned earlier, this is a severe form of hyperthyroidism. What's the trigger here? Same as hypothyroidism, how did they develop myxedema? They got sick, right? They got sick, they got ill, or they experienced some form of stressor. Okay, same thing here. So thyroid storm, also called thyrotoxic crisis, is a severe form of hyperthyroidism. Abrupt onset. It can be fatal. So let's look at the trigger first. So how do they develop hyperthyroidism? Any stressor. By stressor, what's a stressor to you, Ms. Latouche? What do you consider a stressor besides the exam earlier, which was very easy? You have no stressor? Like you don't, are you married? You have kids? You're single? Isn't that a stressor, being a single? Being single? You have lots of money? Oh, that's a stressor. Okay. Okay. You have a crush on somebody? Wrong with you? Okay, so all of us have different stressors, yeah? So we consider something, so let's say I'm afraid of heights. So when I look out the window, that's a stressor for me. So if I have hyperthyroidism, can that trigger a thyroid storm? Yes, as simple as that. So most of the time, these patients got sick, okay? So maybe they got COVID, or maybe they're post-op, okay? They had surgery. So that is a stressor, correct? So hyperthyroid patients who undergo something stressful, they are automatically monitored for thyroid storm. So it's very vague. The trigger is very vague. However, the manifestations are the same. Here are your manifestations. The temperature rise here does not have to be a fever. I repeat, the rise in temperature does not have to be fever. Meaning, if my baseline temperature was 97.5 and I increase to 98.5, is that a fever? That is absolutely normal, yeah? But that 1 degree rise is already a manifestation of thyroid storm. A 1 degree rise in temperature from baseline is a manifestation of thyroid storm. So I don't have to wait until they reach 100, 101, or 102. I monitor the baseline temperature. So let's say I started at 98. 99 is already a symptom of thyroid storm. Okay. Heart rate, extreme tachycardia. These manifestations here are usually caused by hypertension, severe hypertension. So they'll have GI symptoms, they'll have chest pain, dyspnea, and then of course with the neuro for really high blood pressure, dizziness, a headache, pain in the back of the neck. So these are all your manifestations of thyroid storm. Now, here are other forms of stressor. The chapter mentions a few. Okay, so injury, infection, surgery, tooth extraction. Okay, so is this really specific? No, it can be anything basically, right? Anything stressful can trigger thyroid storm. Okay, so once we see these symptoms in a patient with a diagnosis of Graves' disease or hyperthyroidism, what is our next action? Here are our interventions. Cool them down. Give oxygen. IV access and start fluids. And then we give either, okay, not both. We give either of the two thionamides, either propylthiouracil or PTU or methimazole. These drugs are what we call anti-thyroid medications. When we say anti-thyroid, what do they do to the thyroid? They destroy thyroid tissue. Okay. Hydrocortisone, this is a high dose steroid because this is life-threatening. So we give steroids to treat shock or adrenal insufficiency, and then iodine. Now for iodine here, because What will happen to your T3, T4 levels when you take iodine? Say you're taking iodine supplements or eating iodine, fish or any other seafood or iodized salt. Okay, you have iodine, yeah? So what will happen to your hormone production if you increase iodine intake? It will increase it, yeah? Because the main raw material you need to make T3, T4 is iodine. Without iodine, you can't make T3 or T4. So in the same way, if you take iodine, what will happen to T3, T4 levels? It will increase. Okay. Here, the iodine that they mention here is in the form of a high dose of iodine because just as small doses of iodine can increase T3, T4 production, high doses of iodine will actually have an opposite effect. High doses of iodine will actually suppress hormone release. Let me explain it this way. Who has gone to or remember going to a buffet? Okay, Fernando. How many trips do you usually go when you do go? Once or once a quarter, once every 3 months. Three, right? I can go more than that. I'll go maybe 4, 5. Okay. My fifth would probably be dessert. Yeah. I'll go for fruits, some cakes. Yeah. Yeah. All right. However, after the fifth trip, then somebody offers you more food. What are you gonna say? You're gonna go, right? Same exact effect. If you flood the patient's system with so much iodine, what will the thyroid gland say? No more, no more. Okay, so it will actually suppress thyroid activity, if that makes sense. Does that make sense to you? All right. So we give it in this instance, and also later when we prepare the patient for surgery, iodine preparations is also given pre-op. Okay, I'll explain later when we get to the surgical management. So any question on the management for thyroid storm? So these are your actions, okay? So very good, select all that apply. Question for exam 2. Now I'll go back here under the causes of thyroid storm. So can radioactive iodine cause or trigger a thyroid storm? It is iodine. Yes or no? Yes, it will cause thyroid storm. So that's why you see in the chart 45-6, what did the order say? Did we give the iodine first or the PTU or methimazole first? What order is this? Which came first? Iodine or PTU or methimazole? PTU or methimazole first. And then iodine came here. Okay. The rule actually is if you're going to give both, you should give it 1 hour after PTU or methimazole. Again, how long? 1 hour after. Why? Now, let me explain how PTU or methimazole work. These two drugs prevent iodine from binding in the thyroid gland. I repeat, PTU and methimazole, how they work, how they destroy the thyroid gland and therefore lower T3, T4 levels is whatever iodine you take is not going to bind in the thyroid gland within an hour. So therefore, when you give the iodine preparation here, will it cause a thyroid storm? If you gave it 1 hour after PT or methimazole, it will not cause a thyroid storm. Does that make sense? Unique. You have something you wanna know? You need to go to the bathroom? Okay. All right, so iodine is a trigger for thyroid storm. Okay, just to make sure. So that's a guide here for you, just a warning. So when you implement thyroid storm management, what do you give first? PTU or methimazole first. And then 1 hour later, you give the iodine preparations order. Are we clear? All right. Okay, so we have table 45-1. We have two antithyroid medications. So I'll go to the table here, PTU and methimazole. Look at the action. Block synthesis of hormones, inhibit synthesis of hormones. So therefore, they block iodine from binding in the thyroid gland. Without iodine, can you make T3, T4? No. So that's how they destroy basically the thyroid gland. That's why they're called antithyroid medications. Here are your nursing considerations. I won't read that for you. Responsible for that for exam. Now the three iodine you see here, the iodine solutions, we have the iodine solution mentioned under thyroid storm earlier come in three forms. It's either sodium iodide, potassium iodide, or saturated solution of potassium iodide, SSKI. All of them are iodine preparations. And what did you learn in pharmacology when you give any iodine preparations? How should you give it? Straight up like this in a shot glass, like that. How do you give it? With a straw, remember? Because it will stain the tea. Okay. So here's the instruction. Give 1 hour after PTU or methimazole. Are we clear? Why again 1 hour? To prevent what? To prevent thyroid storm. And here again, the beta blocker. Is this going to affect the hormone levels, the T3, T4 levels? How, Ms. Dangquan? How does a beta blocker affect thyroid hormones? So how does it affect? We're talking about the thyroid gland. So does this affect the thyroid gland? No, this is only for the symptom, the cardiac symptoms, right? I mentioned this earlier, eh? All right. Surgery. So reserved for special circumstances. For example, pregnant women who are allergic to antithyroid or cannot take antithyroid. Okay, so if it fits, if surgery is an option, then here we are. Now, the surgery here depends. How much of the thyroid will be removed? If it's subtotal or partial thyroidectomy, will the patient develop hypothyroidism? If it's subtotal or partial thyroidectomy? No, they will not. Okay? They may be hypothyroid for maybe a few weeks until the remaining thyroid tissue compensates for the production. Okay? However, if the whole thyroid gland was removed, will they develop hypothyroidism? Yes. So that explains it here. Right? So before surgery, how do we prepare the patient? Remember, why is the patient's thyroid gland so big in hyperthyroidism? Why is it enlarged? No, remember, just like the penis, why is it so big? Okay, the blood flow is so high. Okay, so that the large blood vessels are so large, so that's why it enlarged. Now, what will happen if you take it out in that state? The blood vessels are so enlarged, blood flow so high, and then you cut it out. What will happen? Bleeding, hemorrhage is guaranteed. So what do we do before we cut it out? We treat the patient first with iodine solutions or antithyroid, whichever is an option. Okay, again, let's say this patient is pregnant. Okay, yes, teratogenic, but if you read the drug book, it's not mentioned here in the chapter, but in the drug book, it's actually very specific regarding methimazole and PTU. One of them can actually be taken during the first trimester, right? So it's not mentioned here, so I can't test that. No, it's not fair. It's not mentioned in your textbook. However, the doctor will decide. Okay, so let's say depending on which trimester the patient's at, they can treat them with antithyroid medication, and if also okay, we can do a radioactive iodine. So let's say there's no radioactive iodine, so we just do with we can do antithyroid PTU or methimazole, and then we'll give the potassium iodine. Okay, so potassium iodine is necessary for a pre-op patient or before thyroid surgery, because this will suppress thyroid activity. So what happens to the blood flow to the thyroid gland? It will decrease. So the gland will get smaller and smaller. Once it's close to normal size, then the patient will be scheduled for surgery and they will not die of bleeding. Are we clear? So this is how we prepare, again, iodine solutions, and we'll treat them with propranolol, the beta blocker. So here, the iodine medication will be given. Post-op care, let's do post-op care here. I remember it's not in this section. It's under thyroid cancer. Right here. Okay, right here. So did you see where I went? Okay, so for pre and post-op care for thyroidectomy, it's under thyroid cancer. Okay, it's not under hyperthyroidism. Okay, page 1469. All right. So here we are, we're preparing the patient for surgery and then receiving them after surgery. So we're only concerned with pre and post-op care. So pre-op, this is hyperthyroidism, yeah? So therefore, what happens to what is their metabolic rate again? High or low? Don't be afraid. Say it out loud. High, okay. So what happens to their calorie needs? Also very high. So what diet will we give them before the surgery? High calorie. So high calorie, high protein diet. Okay. To make sure they survive surgery, because now when they have surgery, do they need to heal? Yes, so we need to give them enough calories so that they can heal post-op. Okay. So in fact, were they malnourished before the surgery? Most likely, yes. They're probably in a negative nitrogen balance because of the hypermetabolic metabolism of the body. So very high daily caloric intake, high protein, high calorie, and we avoid stimulants. Okay, we already have high heart rate, so we don't need any more coffee, soda, or a Red Bull. Okay, so nothing like that. And we explain to them what will happen after surgery. So we'll tell them, okay, so you'll have a large incision here, your neck. So the doctor will literally slit your throat and open here and then remove the thyroid gland. So there'll be a bikini incision here, like you know what a bikini incision is, eh? You know what that is? When people have a C-section, they don't do a vertical incision, they'll have a horizontal. Okay. All right. So it's like a bikini horizontal incision. We give, of course, before we got here, remember the patient was on antithyroid and iodine preparations, yeah? Okay, so we continue those treatments. So here, see where the chapter went from pre-op to post-op? Didn't mention intra-op because do we have any role in the intra-op? No, the doctor does the surgery. So after surgery, here is our responsibilities now. So we monitor the patient for the consequences after surgery. So the incision is here. So do we have any breathing concerns here? Will there be any airway inflammation, swelling? Okay, so that's a possibility. So there could be edema of the glottis. There could be bleeding hematoma there and injury to the laryngeal nerve. Okay, so these are our most common problems. So bleeding, airway problems, and laryngeal nerve injury. So we monitor for all three. So in the post-op room, how should we prepare? So the patient post-op will be in a recumbent position. What is recumbent? On their back. Okay, so the recumbent. And will they be flat in bed or head elevated? What do you think? Elevated. So we are at semi-Fowler's or Fowler's position, but recumbent. They have to be on their back. Reason for this is we don't want any strain on the incision. Okay, so that's the most comfortable, strain-free position. So we look at the sides and the back of the neck, as well as the front of the dressing to check for bleeding. Because at the recumbent position, of course, the blood will fall by gravity. Yeah, so there could be it could be bleeding at the back of the dressing rather than in front. You're following me on the chapter, yeah? You have your books open? What do we prepare at the bedside? Tracheostomy set. Just in case the airway closes, then we'll be able to do emergency tracheostomy. Do we need suction and oxygen also set up? Okay, so we'll have all those ready. Of course, we give pain management. It's painful. Okay, so here, semi-Fowler, and the head is supported with pillows. Because do we want the head to be turning side to side? Again, we don't want any strain on the incision. So straight like this, recumbent and supported with pillows. Okay, semi-Fowler position, as already mentioned. There's some swallowing problems here, so expect IV fluids first. So they'll be slowly introduced to a diet. Start with ice chips, gray liquids until they can swallow better. And from clear liquids, then we'll proceed to a soft liquid diet or a soft diet, or maybe stay liquid, okay, until again they're more comfortable. So to monitor for the laryngeal nerve damage, so here are your interventions. Okay, so don't encourage talking, that will strain the laryngeal nerve, right? So please read the rest. Okay, so this warning here, this Q-SYN alert, tells you about impending airway closure. Meaning if you hear narrowing of the airway sounds like stridor, for instance, or wheezing, so make sure you report to the physician so that we can intubate appropriately. Okay, one consequence of removing the thyroid gland is what are attached to the thyroid gland? There are 4 parathyroid glands attached in the back. So if you remove part or all of the thyroid gland, are you removing part or all of the parathyroid glands? Yes, unfortunately. We prepare for that as well. Don't worry, we're ready for that possibility. So since we have a sudden decrease of calcium levels here, because the parathyroid glands, which we will discuss next week, has one job. So the parathyroid glands produce the parathyroid hormone, which has only one effect, which is to raise serum calcium levels. How does it do that? So when our calcium levels in the blood is low, parathyroid hormone is released. This will cause bone to be broken down to release calcium. Does that make sense? Okay. So if you remove the parathyroid glands, we didn't intend to do that. It's just a consequence because you remove the thyroid gland and the parathyroid gland is attached to the thyroid gland. So of course you will have hypocalcemia, right? So severe hypocalcemia because it's zero now. You go from normal calcium levels to now zero parathyroid hormone because you took it out. So now the patient may go into tetany. What are those two symptoms of tetany again? Chevostek's and Trousseau. Okay, so you watch for those. All right. So here's the Trousseau and the Chevostek's. Okay, and the intervention for this is, of course, what do you give? IV calcium. Okay, calcium gluconate will be given. And that's it for today.